Hello. I want to begin by thanking Professors Yellen and Drucker for including me in this program. Over the next 8 minutes or so, I've been asked to speak about the clinical benefit of modern therapy for type 2 diabetes with a specific focus on GLP-1 analogues. Here are my disclosures. So as you can tell from this plot on the left-hand side of the slide, the incidence of complications, cardiovascular complications of diabetes, have been pretty stable in the general population. In the adult population in the US from 1990 to 2010 went from 178 million to 226 million. There was a bit of a fall in the incidence of acute myocardial infarction, but the rate of stroke, amputation, end-stage renal disease stayed pretty stable. Now, this might appear somewhat discouraging, but in actual fact, an examination more closely of individuals with diabetes shows considerable improvement. There's been significant falls in both the risk of acute myocardial infarction and stroke, and smaller falls in amputation and end-stage renal disease. The troubling number, however, is at the top, where there were 6.5 million diabetics in 1990, and now in 2010, there are 3 times as many. And of course, if you look at that incidence rate per 10,000, it's a much larger number than the incidence rate in the general population. So we know that there is continued high incidence and prevalence of cardiovascular complications in people with diabetes. Now, as Ray and colleagues showed in their meta-analysis of the intensive glucose lowering trials, if you try to treat various cardiovascular risk factors in patients with type 2 diabetes, you get differential benefit. Lowering blood pressure and lowering cholesterol seems to have a much more potent effect than lowering blood sugar. In other words, the treatment of diabetes focused on glycemia is not particularly effective at reducing cardiovascular events. But this study was from 2009 and really used traditional glucose lowering treatments. At that time, we had, of course, metformin, sulfonylureas, the PPAR gamma agonists just started using DPP-4 inhibitors, and insulin. The world completely changed, of course, when we began to get new classes such as the SGLT2 inhibitors and the GLP-1 receptor agonists. In this review by Nock, looking at some of the effects of both short-acting and long-acting GLP-1 receptors, you'll see reductions in A1C, reductions in body weight, reductions in blood pressure, reductions in various lipid parameters with the small cost of an increase in heart rate. Overall, the data are summarized here. Most of these data are from individuals with type 2 diabetes without cardiovascular disease. These were in the glycemic efficacy trials, but we see significant reductions in A1C and weight, small reductions in blood pressure, and small reductions in lipids. At the same time, the SGLT2 inhibitors also have many of these benefits, just generally of smaller magnitude. The blood pressure effect, I would say, is equivalent, but the LDL cholesterol tends to move in the opposite direction. So now if we have agents for the treatment of diabetes that have all these pleiotropic effects, if you will, on risk factors, what are their consequences on those cardiovascular events? So here we see now in a meta-analysis by Darren McGuire published last year of the SGLT2 inhibitors used in patients with type 2 diabetes at high risk of cardiovascular events. In about 47,000 patients overall, we see a 10% reduction in the 3-component MACE of CV death, MI, and stroke. If you look specifically at CV death, you see a more impressive 15% reduction, but the real story with SGLT2 inhibitors was the reduction in hospitalizations for heart failure. Very impressive, consistent, robust, 30% reduction overall. If I do the same meta-analysis, which has been published by Kirstensen et al., for the cardiovascular outcome trials of patients with diabetes at high risk of cardiovascular disease now treated with GLP-1 receptor agonists, you get about 56,000 patients with a 13% reduction in the 3-component MACE. CV death is down by 12%, and hospitalizations for heart failure are good news, moving in the right direction, but a much smaller benefit, about 9%. If I exclude those studies that are with the non-human, in other words, the exenatide or lizard-based GLP-1 There's about 35,000 patients with a MACE reduction of about 17%. I want to dive into two of the most recent studies, one of the longest, and one of the shortest. Rewind with almost 10,000 patients with a follow-up of almost 5.5 years, a really well-conducted study with high rates of adherence, shows the following: a 12% statistically significant reduction in the primary outcome of death, stroke, and MI. If you break down the component endpoints, you see there was really no significant reduction in death, all-cause death, CV death, all-cause death, or MI, but the benefit is significant with non-fatal stroke. If I move now to one of the smallest studies, which was Pioneer 6, which is now the first GLP-1 analog with oral GLP-1, with very similar inclusion criteria, what we see is now a 21% reduction in MACE, but did not reach statistical significance. This was because of a small number of events. And the component endpoints shown here are CV death showed a 50% reduction, but one should interpret this with caution given the small number of events. If I then look at one specific endpoint, stroke, I see that of all of the GLP-1 receptor agonists, overall, it's about 16% reduction in stroke. And reminding you of some of these overall data for the other endpoints, this is probably the most robust finding and most consistent finding of the GLP-1 receptor agonist cardiovascular outcome trials. So what does this all mean clinically? Well, this very busy slide is probably too busy for us cardiologists. What we're going to focus on very specifically is right at the top. In type 2 diabetes, drug naive with already present cardiovascular disease or at high or very high risk of cardiovascular events, really one should be using one of these two classes, an SGLT2 inhibitor or a GLP-1 receptor agonist. Notice this is in monotherapy even before the addition of metformin. The further recommendation that is now consistent across both sides of the Atlantic is that in people even on metformin with the same presence of disease or high risk of disease, these two same classes should be used, the important development being irrespective of A1C. Let me end with the fact that high rates of CVD remain a major burden in patients with type 2 diabetes. The cardiovascular outcome trials of GLP-1 receptor agonists in this group support the use of this class irrespective of A1C. And one of the more consistent and robust benefits appears to be a reduction in stroke. Thank you very much.